Oh, thanks so much for inviting me to this. It is so absolutely brilliant to be in a room full of women, and actually not on Zoom. A room full of anything, actually, we'll probably have done, but a room full of women like this is just absolutely brilliant. So I've been involved in providing reproductive health care and advocating for it for 35 to 40 years, which makes me a sort of old woman among us here. I should say, by the way, just as an aside, the baldness is not a result of chemo or anything. You don't have to feel sorry for me. I just want to put that out there. Nor is it a statement of anything. I've just got alopecia, and if you're going to lose anything, your hair is probably the best thing to lose. And I spent quite a bit of time doing the wig thing, and then basically decided that the best thing was to follow the advice that I often give to men who are going bald, which is to suck it up, shave it off, and stop doing bad homemaking. So that's really sweet. So anyway, that's it. So you don't need to hold back on any criticisms or anything. Don't pull your punches. I can take it. Now, I never, ever thought about 10 years ago that I would ever have to stand on a platform again and talk about defending the point of emphasising a particular need for healthcare and services to be provided to women. I never thought that I would really have to do that. When I started work in this area, the notion of women's health being something specific and particular that needed to be addressed was something that was still very much on the advocacy agenda. But I'm really talking about a time there where if you were thinking about birth, and I know that there are some midwives here because I met you on the way in, and you'll know what I mean. It's like back in those days, 40, 50 years ago, the delivery of women was organised very much around the consultant. Babies were not born at the weekend because the consultant had got his golf game that he needed to go to. So stuff was organised around them. Women were not seen as being the important person in that deal of giving birth. And it was exactly the same in relation to abortion or contraception. I remember an absolutely fabulous old obstetrician telling me about the reason why he became utterly pro-choice and utterly in favour of women deciding. And he said that it was when he realised as a man that women were coming to him with a request for a termination of pregnancy, and they were also going to his colleague with a request for termination of pregnancy. And the both of them, even though they were working to the same law, the both of them were making very different judgments about the women's lives. My old boss, David, used to say that if a woman was in trouble and he felt that she wouldn't be able to cope with having the child because she was maybe poor and had children already, then he would be very sympathetic to her request for an abortion. But if she was a middle-class privileged woman, then he really would take the view that she could probably handle having the child. So why would he bother to provide her with that way out of having the abortion? And he realised that his colleague was making exactly the opposite decision, that if a woman was poor and had children already, his colleague would think, well, having one more wouldn't make very much of a difference. Whereas if she was a wealthy woman or she was a student, he would draw the conclusion that her life would be so disrupted that maybe the abortion request should be granted. And the conclusion that David Payton drew, who was one of a big influence on me when I was getting involved in reproductive healthcare, was that at the end of the day, this should be a matter for the woman at the centre of this to decide for herself, and no one else should stand outside and make that judgment. And it cost him a lot. You know, he was a privileged male obstetrician. He never became a professor. And I think it was one of the reasons for that was because his championing of the woman at the centre of healthcare. But I really thought that that was all a bit done and dusted. And I thought it was done and dusted, say that was going on maybe 40 years ago, sort of 10 or 15 years ago, when men started to realise that we had made real gains through championing the healthcare that needed to be provided for women, the breast screening, the cervical screening, the women-centred reproductive healthcare. And they started realising that, you know, there was something about men that was also different, and maybe men's health should also be championed a little bit. And I don't have a problem with this at all. There are things about men that are specific to men. I take exactly the points that Kat's just made. But really, it was a long time before people started talking about testicular cancer. And my husband, who's a university professor with a kind of brain the size of Wales, when he first went for his first prostate examination and he was told to bend over and cough, he had no idea what was going to happen to him, and genuinely came away talking to me as though he'd been sexually assaulted, and asking me if I thought that was a normal way for a doctor to examine his prostate. And then went on to ask me if I had ever had my prostate examined. So, you know, men too did have a particular problem. And one of the things that I thought, though, was striking and important about this was that at no point at that time was there a sense that men's health, prostate, testicles, whatever, would somehow detract from the women's health care. It was a kind of different sex-based need that they would have. So I find it rather astonishing that when we talk about amplifying women, we're talking about something now that is quite different, and that there's a different reason for us to recognise the fragility of the situation, the kind of acknowledgement that there is a sex difference that gets carried into the way that healthcare is seen and is organised. And I have to say, it was a bit of a shock to me when I got into some real trouble, which isn't why I've retired. I got a whole number of bits of correspondence from people checking in with me when I left BPAS to make sure that I had retired voluntarily rather than having been retired. And the reason for that was because suddenly started getting correspondence from people saying that it was kind of wrong for us as an abortion service to be describing ourselves as a women's service, and that it was wrong for me to be arguing that abortion was a women's issue. And I remember talking to somebody about this. I live in this sort of small market town in East Kent, and saying this to someone who I was walking with, and looking at me in a bewildered way and saying, they don't want you to call it a women's service, they want you to call it a ladies' service. Isn't that old-fashioned? And I was like, no, it's about And the point was, as we will now all know, that we were supposed to stop calling it a women's service because that was seen as being non-inclusive. And what we needed to be doing was to start talking about pregnant people. And yeah, but you see, this is it. This is your response to it. I was like, kind of, what the is going on here? And so, I talked to the staff. We had a staff forum, and I'm saying, what's going on here? How many people are we seeing who do not identify as women? And, what I'm told is that we did occasionally see people who didn't identify as women, and that it was in fact becoming a bit more common for people to not identify as women when they were coming into the service, and I can understand that. And I was asking, and how many complaints have we had? None. And the reason for that, I think, is because regardless of what you think of the debates about identification and self-identification and all of that, if you're working in a service, if you're a midwife, or you're a nurse, or you're a doctor in an abortion service, you do your absolute 100% level best to make any patient feel comfortable because you respond to their individual needs. And within an abortion service, that's obviously what you do. We have women who come with a pregnancy that is an unwanted pregnancy because their partner has left them. We have God, I'm doing it myself now. We have women who come to us with a pregnancy that has maybe had a diagnosed fetal anomaly. They want to be treated in very different ways, actually. And you take note of that. And you do the absolute best you can to make everybody feel comfortable about it. If somebody is presenting as a boy or as a man, then you don't want to put them in a recovery area with a bunch of people who are identifying as because they are women. This is not, I argued, a good moment for opportunistic trans-inclusionary education when somebody is coming around from an anaesthetic having followed an abortion procedure. And this has not gone down well, I have to say. It went down fine with the patients, it went down fine with the staff. I think where the pressure came from was really the advocacy movement, who I think are very often a bit of a way removed from what people want when they are actually in these situations. My point was that, over my dead body were we going to change the language, because however you happen to identify personally, that's up to you. Abortion is fundamentally a women's service. And it is a women's service, and it's important that we retain that. I really think for two reasons. What have I done? For two reasons. The first reason is that it speaks fundamentally to a woman, an adult human female's reproductive stuff. And on top of that, it speaks to the way that the fact that we have ovaries and fallopian tubes and a uterus and a cervix and a vagina, how that impacts on us, not just physically, but the way that we see ourselves, the way that we understand ourselves, the fact that we spend a lot of time being terrified that we are going to get pregnant when we don't want to get pregnant, and terrified that we can't get pregnant when we do want to get pregnant. It really influences a lot about us. And abortion speaks to that. It speaks to something in us which is about our bodily integrity and our autonomy. And you can't brush that away. It's not something that you can put on in the morning, like you can put on a dress or a wig. It's not something that you can take off. It's there. And however you self-identify, if you are a woman and you are having penetrative heterosexual sex, that is something that you may need. Contraception and abortion speaks to that. And I think there's another reason why it's important. And the other reason why it's important is because we should not forget that abortion, although it's probably less stigmatized now than it was in the past, it still carries a burden of stigma and guilt. Why does it carry a burden of stigma and guilt? Because, and this is where I go back to an old-fashioned way of talking about gender, it challenges the gender stereotypes, not that we take upon ourselves, but that society places on those who are biologically female. When society says it's okay for you to have children, it's okay for you to be a mother, that is your role, but it's not really okay for you to basically say that you will take control of that and end that natural path when it doesn't really fit with what you want at any particular time. And it is because abortion is a woman's service, because it is a way of women controlling their lives and taking control of their reproduction, of expressing their autonomy and their bodily integrity, even though no woman does it as a gesture to express her womanness. She does it because she's got a particular problem pregnancy that she needs to solve, but it's nevertheless, there is something that is in that there. And that is why when I started in this field nearly 40 years ago, abortion wasn't even fully funded by the National Health Service. It was only 50% funded by the National Health Service. And that is why even now, when there are issues that look at the position of women requiring later abortions, it's seen as something that a woman's decision should be quite properly overridden, because she needs to be told that a late gestation fetus is like a baby and therefore she should become a mother to it, rather than recognising that she is a moral being who can make judgments for herself. So I think we do have to fight this. We can't fight it by ignoring it. We can't fight it by pretending that it will go away. I don't think that we can fight it by just assuming that inclusion, although inclusion always sounds like a good word, is the way forward. I think that a world that really is inclusive when it comes to reproductive health recognises fully and absolutely that women, because of biological fact and being, have a claim to what we are, and that what our bodies are really determines and shapes the essence of what we feel. And it's not a choice, it just is. The choice is what we can do with it. Thank you very much.